to write on a question sheet what are the strategies. Then there are designated spaces where you have to answer or put up the answers itself. And at the end, we will give you a 10 question a set comprising of 10 questions, which will represents the uh, three of that. So rather than giving you a 30 question, it would be a longer practice session for you. So we will give you only 10 questions itself. So now I invite Dr. Mona Lisa Mishra. She is a senior consultant of critical care in Apollo Hospitals, Kolkata, and she is our guiding lead faculty for the domain of nephrology. So many of you know her. She is one of the lead personality in extracorporeal support, so be it your CRRT or ECMO itself. And also she does a lot of work on academics on behalf of ISCCM itself. And she is a very good clinician trained in Gangaram as well as in UK itself. So welcome, Dr. Mona Lisa, and I hand it over to you. You would be sequentially introducing your presenting faculties itself, though they are very known to me, but it is your responsibility and honor to introduce them too. So over to you, Dr. Mona Lisa.
Thank you, Arindam sir. It is a great pleasure to do this course with you. And thank you for giving me nephrology domain. It's personally my favorite. And I have two of my favorites to present the topics to all the exam goers. Without wasting any further time, I'll introduce Dr. Debottam Gangopadhyay. He is working as an associate consultant in Apollo Multispeciality Hospitals. He has just given his exam 2 years back, and he's one of the bright students of that batch. And that's why we chose him, because he knows his subject very well. And he'll be talking about CRRT and rhabdomyolysis, and a little bit about perioperative fluid management and biomarkers for knowing the resistance of diuretics. So all very important topics. And I'll be giving a brief overview of everything after he's done with the presentation. So over to you, Dr. Debottam.
Thank you, ma'am, for your kind introduction. Let us share the slide. So, myself, Dr. Devuttam, and I'll be going to discuss some part of nephrology today in next 1.5 hours. There's a big topic actually nephrology, but in as you guys are going to be give exam within a few 1 and 2 months, so the topic I will try to keep it more exam specific, and by this time you got to know what is what, and you have depth of knowledge regarding each and every topic. So my main motto will be specific to the questions and more exam oriented talk. So I will discuss CRRT, rhabdomyolysis, um, buffer salt solution versus normal saline comparison, perioperative fluid management, and diuretics in AKI. So CRRT is a renal replacement therapy. My colleague Trishita will discuss about acute kidney injury and what is the next management of a renal acute kidney injury and need of renal replacement therapy. So I'm mainly focusing to the CRRT mode, but prior to going into CRRT, I just uh, give the basic overview of modality of renal replacement therapy. So, based on duration, we can divide it RRT into mainly three types. One is intermittent, that is intermediate hemodialysis, that is very common to us. Then continuous process, that is continuous renal replacement therapy, and it has several classification like continuous veno-venous hemodialysis, continuous veno-venous hemofiltration, continuous veno-venous hemodiafiltration, and all. And there is between of these two, that is hybrid therapy, which known as SLADE or slow low efficiency dialysis. I'll come to details one by one, but just a brief of intermittent hemodialysis. So intermittent hemodialysis, as we all know, it is the gold standard, and most commonly we have seen this modality for in our regular day-to-day practice. And usually it takes for maintenance hemodialysis, the patient with CKD on maintenance hemodialysis, they go through this ISD, and usually 2 to 3 times in a week, and for 3 to 4 hours. There is a pump, there is a and filters, dialysate and anticoagulant may or may not recur in ISD. So it involves dialysing with the higher flow rates around 300 to 400 ml per minute. So that is the important. This the flow rate is much more higher in this modality, whereas continuous renal replacement therapy is much more slower rate. So high flow rate, there is a rapid fall of plasma osmolality. We have to keep in this mind. Rapid correction of acidosis, rapid correction of the fluid overload or volume overload, rapid removal of dialyzable drugs. In this concern, we have to remember for prior to practical examination, particularly what are the non-diazable toxin you have to remember, like benzodiazepine, TCA, digoxin, all these things. So minimize anticoagulant exposure. That is important portion of CRRT. I will come to again later. Comparatively inexpensive rather than CRRT. And these are the some saline features of ISD. But indication of dialysis, that remains same. Whatever is modality it is, the indication, the main indication of our renal replacement therapy remains same. Modality depends on patient condition, need, and clinical scenario. So now come to CRRT, continuous renal replacement therapy, which involves filtering and or dialyzing on a continuous basis. As I told earlier, as I discussed this thing, the continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, continuous veno-vena hemodiafiltration, and continuous arteriovenous hemodialysis. These are the most commonly used techniques. These are much more expensive than intermittent hemodialysis and requires continuous rather than intermittent coagulation. CRRT is superior to ISD in patient with sepsis, cardiovascular instability, eh, head injury or right ICP, hepatic encephalopathy, all these scenarios. But if you go through the trials and evidence, the patient with if you compare between ISD with CRRT in patient with AKI and multi-organ failure, there is no difference measured differences in survival. Then what is the advantage of CRRT? The main advantage is it's more of physiological. It's like a physiological kidney. It works like the thing is like that. So hemodynamic as it is slow, so and continuous, the hemodynamic instability and fluctuation of intracaseal pressure is less. We can give it to continuous 24 hours treatment, but practically 24 hours is not possible, not feasible also. Uh, there is unlimited fluid and waste removal that is possible, and also from the there is improved nutritional support because no need of volume restriction as such that we done usually in CKD patients. So good control of metabolites, better control of volume fluids are possible in case of CRRT, and elimination of septic mediators, that's also an important point. Now hybrid therapy is a slate this between some points of CRRT and some of ISD. Both are present in case of SLADE or hybrid therapy. That is slow, low efficiency hemodialysis. So we can give SLADE, as we all know, we have seen everybody of us has seen the SLADE, and it's same machine. For CRRT, there is a separate machine we have required, but in SLADE, we have same hemodialysis machine, intermediate hemodialysis machine is required with blood flow of 200 ml per minute and dialysis for 100 to 200 ml per minute. The time usually duration is 6 to 8 hours. Now, what is the advantage and disadvantage between SLADE, CRRT, and ISD? This is an important question for exam perception. As I discuss all these things, this is charted over here. The potential settings of in AKI, if I do ISD, mainly for hemodynamic stable patient, we have to go for ISD. This is a rapid removal of the toxin and low molecular weight substance, allow downtime for diagnostic and therapeutic procedures, reduce exposure of anticoagulation, and lower cost than CRRT. This is the advantage of intermittent hemodialysis or conventional hemodialysis. Disadvantage, So rapid fluid removal causes hypotension. Dialysis dysregulation syndrome because of rapid reduction of the plasma osmolality. And technically, this makes the technique is more complex actually. But in case of CRRT, the fact is that there is a need prolonged anticoagulation, need patient to immobilize. There is a high risk for hypothermia, and the cost is the very expensive. That is the another thing of disadvantage of CRRT. Whereas SLADE is in between two, as I discussed earlier. So there is slower clearance of toxin, and it is technically little complex, and there is a not a good as low efficiency, low efficiency dialysis. So this is the basic circuit. Imagine these things. This is the main circuit and basic circuit for hemodialysis. If you remember this circuit, you can add and add something to make another thing. That means if you add some replacement fluid or you can add dialysate, you can change the modality accordingly. But the basic circuit is like this only. So there is a access limb and there is a return limb and there is a filter. So one is access limb, three is filter, and five is the return limb. Just remember this picture only. Now I come one by one, and uh, every circuit and every modality you can understand by these three, this only. So what are the principle? There is mainly three process in waste removal. One is diffusion, next is ultrafiltration, and convection. This is the main three uh, process or principle by which the CRRT works. Okay, actually the dialysis RRT works, better to say. So diffusion, as we all know, the movement of solute from high concentration to lower concentration, that is, its diffusion means concentration gradient through a semi-permeable membrane. So that is the fact of diffusion. What is convection? And there is a movement of solute through membrane by the force of water. So there is a solvent drag. The solute drag is there. There is fluid movement, and it along with the fluid there is a dragging of the molecule. So this is called convection. And there is a term ultrafiltration. In ultrafiltration, what happened? The passage of the water through a pressure. The pressure dependent is ultrafiltration. So if we go to the modalities, as I discussed earlier, this is so in CVVH, that is continuous venous hemofiltration. So this is the filtration takes place in this modality. So CVVH, if it is D is there in the term CVVHD, that's a dialysis. That means diffusion. D for diffusion, D for dialysis. So in case of dialysis, there is a diffusion principle method is used, and there is a HDF, that is hemodiafiltration. Then both things are incorporated into that. So what are dialysate and what is the replacement fluid? So if you go through this slide, this one, it will be easy to understand. Now, think like this way, there is a one is access port and one is return port. And in between access and return port, this is a nothing but an extra corporeal circuit like that. So there is a access port and there is a return port. Between that, there is a extracorporeal circuit and with a filter. So blood comes from the patient body, go through the filter, and filtrated or detoxified blood comes into the patient body. So the detoxified blood comes in the patient body, but remnant of that, the portion that is filtered by the filter or by the machine is known as effluent. If we go this procedure only, blood comes from the body patient, go through the filter and return back to the patient. The remnant product through the filter, the filtered product, that is only liquid or only water. This is used for volume overload purpose. This is known as ultrafiltration, slow continuous ultrafiltration or SUCF. There is no need of dialysis, there is no need of replacement fluid and all. So this is the basic thing, that is SUCF. It is used to treat for volume overload. But volume removal rate is very slow, around 100 ml per hour. So this is the basic principle. Now, what is dialysate and what is replacement fluid? So any fluid used to opposite side of the filter, that is known as dialysate in case of hemodialysis. So usually a crystalloid solution. As dialysis, as I told earlier, this is a method of diffusion method. So there is a concentration dependent exchange of solute. So in this case, so if the patient having higher concentration of that toxic product, we have to remove it. So by concentration gradient, that one until it equilibrium reaches, the higher concentration that is present in the patient's body through the semi-permeable filter is come into the dialysate. So there is a flow of dialysis is required. That is the concept of hemodialysis. So in CVVHD, continuous veno-venous hemodialysis, there is a dialysate. So effluent, that is earlier, as I told, in SCUF, there is a effluent only containing of fluid. But in this case, effluent means including effluent plus dialysate. It is the ultimate outcome or ultimate product of after the dialysis. So there is one access through filter and dialysis to the opposite side. Through the filter, diffusion takes place and the rest of the content comes out to the body, and after that purified blood return back to the body. So one from the body then to the body. Now filter, and then comes to CVVHDF, that is continuous veno-venous hemodiafiltration. So in this case, things happen. Everything can be, both high molecular weight, low molecular weight, and the fluid. All things can be removed possible by CVVHD. Here we use all the dialysis, diffusion, ultrafiltration and convection. As I told earlier, movement of solute through the membrane by force of water. So solvent drag method. So middle and larger molecule mainly comes through this convection method. But to remove the this kind of replacement fluid is there for convection method, because we need some amount force to help or to drag the solvent. So their replacement fluid that could be pre-filter or post-filter fluid. So replacement fluid is used to increase amount of convective solute removal in during CRRT. Replacement fluid does not replace anything. We have to replacement fluid. Name is replacement, but it does not replace anything. It just help the procedure of convection. That's the thing. So usually, normal saline is used as a replacement fluid. It can be pre or post filter. So ultimately, the product pre-filter and post-filter, whatever it is, it contains everything in CVVHDA, that means continuous veno-venous hemodiafiltration. The ultimate products is comes with effluent and dialysate and pre or post replacement fluid. So again, CVVHD, that is clearance by diffusion. Anything D, dialysis is diffusion. Balanced fluid is pumped into one end and dialyzer and the effluent pump pulls it out again from the other end of the waste bag. So waste bag contain the toxic product along with the fluid and removal along with the dialysate. So it passes, as it passes through the hollow fibers, solute less than 30 kilodalton diffuse across the fiber membrane according to their concentration gradient, moving from higher to lower concentration. The greater the concentration gradient, the faster the solute transfer. Now CVVH, clearance by ultrafiltration and convection. So as I told, already discussed, that is replacement fluid is required in this case. So it is before filter or the after filter both can be happen. If we use for before filter, this dilute the blood, reducing the clotting risk. So that is help in that case. So there is a, as it is the blood from the patient comes to the extracorporeal circuit, there is a high risk of clotting. The chance is much more in these patients. So if we use replacement fluid pre-dialysis before the pre-filter, that is before the filter, then the risk of clotting is less in pre-filter cases scenarios. But after the filter or post-filter, it maximizes the clearance, but the blood is hemoconcentration as it go through the filter increase clotting risk. So risk is much more if we use in post-filter. And CFF HDF. So both ultrafiltration, convection, and diffusion. This is more usually used in for CRRT purpose, and it contains everything as I told. Both dialysis, replacement fluid, and the normal toxin. Now, essential steps in CRRT prescription. So we have to decide the indication to start CRRT, whether the patient having high intracranial pressure or hepatic encephalopathy or is hemodynamic unstable, septic shock, all these things present or not. If it is, then we have to think of CRRT. After that, we have to prescribe accordingly. That is the vascular access, size, location, hemofilter, appropriate size, bloodline set, priming solution, blood flow, modality dose, what is the replacement fluid required or not, dialysis fluid required or not, prescribed fluid loss rate, prescription of electrolyte correction, sodium correction, potassium correction, calcium phosphate, we have to keep in mind that too. Anticoagulation, dose, modality and monitoring, I'll come in later. And drug dosing, this is antibiotic dosing. These things are very much important for prescription of CRRT. So what is the study says? Most of the study says actually if you go through the studies, there is a multiple study regarding the exact dose of CRFTs, and it comes actually around within 20 to 25 ml per kg per hour. The dose usually written like ml per kg per hour. There is a study with high rate and low slow rate study around 35 to 40, and comparison has done between 20 to 25. So most of the studies has been ultimately discussed. Usually there is a two type of prescription actually. One is desired prescription and one is prescribed and drug delivery, and another is uh, effective drug delivery, because we can't do practically 24 hours duration for CRRT is not possible, because there is there's a we may ship the patient to the CT scan. During that time, the effect of we have to stop the CRRT, but whatever any reason, any patient is that much critically ill, for a time being we have to stop the CRRT. For ultimately the total prescribed dose is not received by the patients. The drug dose is not adequately as per our prescription. It may be changed according to the condition of the patient. So uh, in that case, actually, we have to change the dose or modify. You have to modify the dose. So prescribed dose and delivered dose are not the same thing. So usually we use 20 to 25 ml per kg per hour doses. So this is the goal, as I told. So this calculate like to this formula dialysis rate with pre-dilution replacement rate plus post-dilution replacement rate and patient fluid removal in ml per hour. And these are the summary of initiation of continuous replacement RRT prescription. Usually, as I told earlier, we usually use CVV HDF, and this is the actually typical prescription. I have write it down, but it may vary according to patient condition and need. So, but the thing is that 25 ml per kg per hour is the average. There is a multiple risk of filter loss of CRT filter efficiency, and due to loss of filter surface area due to clotting or air. There is loss of permeability due to clogging, clotting, absorption, and concentration polarization. So there is a multiple interruption in the treatment is there, chance of there. So that's the thing. That's why the concept of this prescribed and delivered dose is little different, not the same. So delivery dose usually recommendation is more than 80% of the prescribed CRRT dose that we have to achieve. Now the studies, as I told, discussing earlier, there is a renal, ATN, Tolwani, Soden, Bowman, and multiple studies there, and it says ki a mortality benefit and groups, one is 40 cc per kg per hour, and another is 25 cc per kg per hour. In renal study, so there is a multiple study goes on high and low rate, low dosing of CRRT, and after doing some RCT and recent RCTs, and uh, high dose therapy does not lead to any improved clinical outcome and may lead to adverse outcome, including hyperkalemia, hypophosphatemia, and excessive removal of antibiotics. So after that, it is more or less we use rather low volume, 25 to 30 ml per kg, may be the appropriate, with the target of delivery dose around 20 to 25 milligram per kg per hour. Now, CRT filtration factor. How do you calculate filtration factor? Filtration factor is the ratio of being fluid being removed from the filter to the fluid entering into the filter. That is fluid removed from the filter, that is the ultrafiltration, and fluid entering into the filter, that is pre-filter replacement fluid plus plasma flow rate. Timing of RRT summary, as it will be discussed by my colleague in later on. Just a cross picture. There's a you must know by this time these things. There's a controversy still is there. What is the best time to start RRT? There is a multiple study like ELAN study, AKI study, ideal ICU study, and start AKI study, and some shows no difference, some shows there is a few differences there, but yet to decide what is the actual timing or RRT. Uh, we can say there is a definite indication when there is a hyperkalemia, when there is a severe metabolic acidosis, and there is a volume overload, there is a toxin, uremic syndrome that they are. These are the definite indication of starting of RRT, that we know, but whether early is beneficial or later is beneficial, that is yet is a topic of controversy. Now, anticoagulation. In continuous renal replacement therapy, we have to know about anticoagulation. Why? Because as I told, it is a extracorporeal circuit thing. When blood is a foreign surface to contact, so mechanical compression, blood clamp, low blood flow, prolonged treatment, and procoagulant state is present like COVID-19. In fact, any sepsis can lead to procoagulant state. So all these things can lead to risk of clotting. So anticoagulation is needed, particularly more with CRRT, continuous renal replacement therapy, because the slow procedure, blood remains in the extracorporeal system for more time rather than intermittent hemodialysis. So anticoagulation, that could be systemic or that could be regional. So in systemic, there is a risk of bleeding. Definitely, in a critically ill patient, in sepsis, septic shock, there is a other way picture too. There is hindrance of bleeding too. For CRRT, if we give systemic anticoagulant, there is a more risk of bleeding. Must be suspended for procedures. We have to stop the anticoagulant for any procedure like tracheostomy and all. Heparin induced thrombocytopenia, there is chances there, and often inadequate. That may not be adequate for the our purpose. But if it is regional, that will be risk of systemic bleeding is less. So improves filter life, improves circuit permeability. But the thing is much more complex than systemic one. In systemic, we can give some injection or subcutaneous dose, and but regional is not like that. I'll come how regional uh, anticoagulation works. So this is a publication published article in JAMA actually, in critically ill patient with acute kidney injury and regional citrate anticoagulation versus systemic heparin anticoagulation. They have a intervention. They have 596 patients was analyzed, and 300 of them used regional cited anticoagulation and 296 systemic anticoagulation. And outcome actually shows that 90 days mortality is not clinically significant, but with regional cited anticoagulation, the shelf life of the life filter lifespan is improved. Now, what is that? Regional citrate anticoagulation. It is a safe and effective anticoagulation for most of the ICU patient on CRRT. It is based on ability of citrate to prevent coagulation in extracorporeal circuit by binding and chelating free ionized calcium. One molecule of citrate binds two calcium ion forming citrate calcium complex. Regional citrate anticoagulation requires close monitoring, especially upon initiation of therapy. RCA has associated with significantly less bleeding, less blood transfusion, and extended life of the extracorporeal circuit. So calcium citrate complex, and as this picture shows, 35% or to 50% removed by dialysis across the hemofilter, depending on the flow and rates of and red blood flow rate and citrate. And rest can be taken by liver, kidney, and skeletal muscle and form bicarbonate. So general protocol consideration: citrate induced at earliest point as possible to the circuit before the filter. Replace calcium at the end of the extracorporeal circuit or through the separate line to replace calcium that is chelated and lost, and must ensure that dialysis citrate infusion and calcium infusion are started and stopped it simultaneously. So this is the whole picture to your better understand. The citrate we have to give prior to the filter, and calcium containing replacement fluid we have to give to uh, replace the calcium. So we have to watch these electrolytes and acid-base disturbance associated with citrate anticoagulation. So what can we happen? We use citrate anticoagulation. Number one is hypernatremia. Citrate solution may have high sodium content and should be paired with a lower sodium dialysate and replacement fluid. So to make it neutralize. Hypomagnesemia. Create citrate binds with magnesium. And this complex is removed via CKRT from the circulation and causes hypomagnesemia. Hypocalcemia. Citrate can bind pre-ionized calcium. So, if the total calcium and ionized calcium ratio is more than 2.5, then we have to think about citrate toxicity. So, anion gap metabolic acidosis. Citrate is a weak, unmeasured anion. So, liver dysfunction or any low mean arterial pressure may increase citrate accumulation by impairing citrate metabolism. Then metabolic alkalosis by bicarbonate that can accumulate and causes the metabolic alkalosis. So citrate accumulation and citrate overload, these both can happen. Mechanism: citrate accumulation, incomplete citrate metabolism, persistence of circulating citrate calcium complex in the blood. Whereas citrate overload, when citrate we have administered citrate in excess amount, so that can lead to citrate overload. So if citrate accumulates, it causes metabolic acidosis. If overloaded, then it causes metabolic alkalosis. So calcium, total calcium is to calcium ratio. That is important. If it is increased, we have to think about citrate accumulation or citrate toxicity. Increased need for calcium substitution, trend for a decreased ionized calcium level. So that also indicates citrate accumulation. Citrate accumulation is rare, but citrate overload is much more common. If citrate net overload occurs, we have to decrease the blood flow or increase the dialysate flow rate. Whereas in citrate accumulation, Then we have to decrease the blood flow or increase the dialysis flow rate. Consider alternative anticoagulation strategy to be better to do that. Outcome potentially lethal, and cited accumulation, cited toxicity is very lethal condition, whereas overload is easy to fix. Anticoagulation consideration, what guideline says in ECAG guideline KDIGO 2012, for patient without an increased bleeding risk or impaired coagulation and not already receiving effective systemic anticoagulation, we suggest for anticoagulation in CRRT, regional cited anticoagulation rather than heparin in patients who do not have contraindication for citrate. And those who are not receiving anticoagulant, we suggest we suggest regional citrate anticoagulation rather than no anticoagulation during CRRT in a patient without contraindication to citrate. So ultimately, if there is a no contraindication to citrate, regional citrate anticoagulation is preferred over systemic anticoagulation. So that's all of CRRT. I hope I try to understand you. And as you guys know, if you have any question, you can ask me later after the finishing my talk. So rhabdomyolysis, again, it's exam-oriented topic. Could be come as a short note. Just important things you have to know. What is this? What is the clinical features? How it presents? How do we manage and how do we treat it? And what is the complication of rhabdomyolysis? So rhabdomyolysis, rhabdo means striated, myo means muscle, and lysis, so breakdown. So condition that occur, that is breakdown of skeletal muscles. So it occurs in the ward earlier. It is first described in the victims of war and higher mortality, particularly associated with AKI. So normally, rhabdomyolysis mortality is around 20%, but when it's associated with AKI, mortality increase up to 50 to 60%. So etiology, trauma, crush injury, burn, electrocution, toxic or drug-induced alcohol, statin, cocaine, all these things. Sepsis, definitely. Malignant hyperthermia, seizure. We usually do CPK and sometimes do whether it is seizure or pseudo seizure. Strenuous exercise, very common in army personally. These kind of things and have seen. Genetic mitochondrial defect can also lead to rhabdomyolysis. Clinical presentation, the thing is that it is non-specific. Classical symptom of myalgia, myoglobinuria, that is tea color urine, and the weakness seen only in 10%. Muscle pain, swelling, bruising can be there. Fever, malaise, confusion, agitation, low urine output are present in some of systemic presentation. So all over, it is not non-specific symptoms except that myoglobinuria, that is tea color urine. Rest all can mimic with multiple cases, multiple diseases. So diagnosis, we have to suspect, we have to suspicion is important. Elevated creatinine kinase is the hallmark. A value 5 times of upper limit is highly suggestive of rhabdomyolysis. Serum and urinary myoglobin is also become positive. The diptych test of urine myoglobin is sensitivity of 80%. So high urea, creatinine, hyperkalemia, high phosphate and uric acid, high anion lactic acid disease are indicative of muscle breakdown. So all these things we have to keep in mind with background of the etiology. So these could happen. We have to check all these things and whether the patient is going to rhabdomyolysis or not. It is important because it is a medical emergency condition. So treatment of underlying cause is important. Fluid resuscitation is most priority. Target to maintain urine output of 3 ml per kg per hour. There is a lack of evidence of urinary alkalization with sodium bicarbonate, but we usually give sodium bicarbonate. And theoretically it has some benefit of doing urinal alkalization, because if you keep urine pH more than 6.5, so there is a reduced precipitation of TAM salt for protein, but can aggravate hypokalemia. Despite of normovolemia, if urine output remains low, then the mannitol can use, but it discontinued if urine output not improved. Mannitol have to be, we have to discontinue mannitol if urine output not improved or osmolar gap increases more than 55 osmol per kg. So complication. So management portion is important for abdominalysis. Apart from fluid, we can't do much, not much anything we can do for these patients. Urinary alkalization we usually do, but no that much evidence. Mannitol we can give, but again it has some renal failure and high creatinine. The use of mannitol is little bit tricky. So what are the complications? Acute kidney injury, that is the most common and most guarded complication. Release of myoglobin, and this myoglobin lead to oxidative damage and formation of inflammatory mediators. This cause intrarenal vasoconstriction, direct cellular injury to proximal convoluted tubule, and precipitation of TAM Hall protein and leading to AKI. Hyperkalemia due to muscle breakdown and DIC can occur. So all this is like a chain. So this enough, I think this is enough for your exam purpose. That can come in an exam as a short note. What is rhabdomyolysis? What are the etiology of these things? How it clinically presents, and what is the diagnosis and the management along with the complication. Now comes to balanced salt solution and normal saline. So what is the problem with normal saline? The most commonly used fluid till date in ICU and ward is normal saline. It is quite cheap and very long. Many of through the many years we are using this, but there is some adverse effect as we know by this time. According to Swart physiochemical approach, pH of a solution depends on the partial pressure of carbon dioxide, total concentration of weak acid, and strong ion difference. So, strong ion difference, that is sodium, potassium, calcium, magnesium, and the difference between chloride and lactate. So now normal saline solution contain 154 millimole of chloride and 154 millimole per liter of sodium. So if chloride level increases, the strong ion difference decreases. This causes water molecule to dissociate to H plus ion to maintain electrical neutrality. So this rise of H plus ion concentration lead to acidosis. So that is the cause of hyperchloremic metabolic acidosis by transfusion of normal saline. So this is the thing of concern. And another thing is what happened with kidney. In kidney patient, the nephrology to machine the not do not prefer normal saline for fluid of choice because macula densa triggers vasoconstriction in the afferent arterioles when there is a high chloride load in the kidney. This in turn causes reduction in the GFR. So this tubuloglommular feedback phenomenon can cause impairment of the renal function. So this is the one of the important thing. That's why we have to cautious with normal saline. Now, what about BSS? That is balanced or buffered solution. These contain different organic anion like lactate, acetate, malate, pyruvate, gluconate to maintain the electrical neutrality. So there is a H2O dissociation level of increase of H plus ion does not occur. Despite of having electrolyte content closer to the plasma, balanced solution are neither perfect or nor physiological. The concentration of these organic anions present in these solution are much higher than those of plasma. Buffering substance in the balanced solution, that is lactate, acetate and all, are metabolized primarily in the liver, and compromised liver function may affect metabolism of this substance. So we have to cautious with BSS too. What or rest lactate contents of ringal lactase is 25 times more than that of plasma. High level of acetate may lead to hypotension and can cause myocardial depression actually. Plasma gluconate elevation following plasma-like infusion can lead to false positive tales of galactomannan. Co-administration of balanced crystalloid with blood transfusion, that is the theoretical concern because calcium salt being present in the ringal lactate or serofangin and the possible precipitation of citrate and clot formation is there if we use this solution along with the blood. So these are the concern. But what to do and what the evidence is. There is split trial in 2015 and done in 4 ICU in New Zealand. Plasma light 148 with normal saline. The outcomes shows do not there is no difference in AKI and the requirement of RRT or mortality if we use plasma light 148 or normal saline. Now in 2018 there comes smart trial in USA. This is a single stent center study. Plasma light A or lactated ringer solution with normal saline. Same, there is no difference in the mortality, ventilator free days, but major adverse kidney events associated with NS. So normal saline group, this is a smart trial, shows there is some problem with normal saline, particularly in kidney related problem if we use normal saline. Then 2018 is again in USA, but it is emergency department, not ICU. They done a salted trial. Plasmalite A or lactate with normal saline. Major adverse event kidney are less with BSS, balanced salt solution. So again, advantage with BSS. Now, PLAS trial 2022, 53 ICUs in Australia and New Zealand, Plasmalite 148 with normal saline. There is no difference in RRT 90 days mortality, ICU free days or hospital free days. Now, this is an Indian study, and that's why it is important. Solute study, and that is a salt-based or balanced solution. Trains existing in the Indian intensive care unit, a multi-center prospective observation cohort study, and that is published in 2024. And these two showed that there is some benefit with balanced salt solution. So there is a mix. Some studies showed balanced solution is better than normal saline, and some shows there is a maybe benefit of normal saline. So what the recommendation says? So surviving service guidelines suggest buffer salt solution over normal saline. 0.9% saline is still useful in certain clinical scenarios like resuscitating patient with raised intracranial pressure, hypovolemic hyponatremia, hypovolemia with metabolic alkalosis, and in a resource limited setting. So currently there is no high quality clinical evidence comparing different balanced salt solution. That also concerned whether ringer lactate or whether it is the plasmalite, which is better. There is no study between these balanced salt solution. So choosing the right balanced fluid is largely based upon physiological data and the cost. So in conclusion, we can say there is the meta-analysis and all did not reveal any significant difference of 90 days mortality with balanced crystalloid compared to saline. So balanced crystalloid may be preferred for resuscitation on fluid in a heterogeneous population of critically ill patient, but choice of fluid will be depend on the condition of the patient. So that is also exam related talk. Next is a not that important, but better to know prior to going to exam is perioperative fluid management. So outcome of surgery depends on the multiple factors. Fluid regulation is important among them. The type of surgery, uh, type of the fluid we are giving, the rate of fluid, the comorbidity condition, what surgery we are doing. These things also important for the outcome, but fluid is also important, is equally important what fluid we are giving and what the rate we are using. Now replacement fluid and maintenance fluid. So patient requirement, there is a two type of fluid we can broadly classify. One is replacement and one is maintenance. Replacement fluids are necessary to treat existing deficit or compensate for ongoing losses during the perioperative period. Uh, so the patient on NPM that there is a deficiency, we have to replace that thing. So the Common replacement fluid in the perioperative period include normal saline, ringal lactate, balance of solution, all these things. Whereas maintenance fluids are those required for optimization of the ongoing losses due to physiological process in order to maintain homeostasis. Stasis. The common maintenance fluid are dextrose containing saline, all these things, and isolate solution. Now, a little bit third space. I know most of us intensivists are nowadays are from the background of anesthesia. They know all these things better. So, what is third space? The loss occurring due to the fluid shift from the intravascular to the extravascular compartment during the surgery is known as third space loss. This third space loss follows edema at the operative site and evaporation from the surgical exposure. So we have practiced all these things. There is a multiple formula of calculation of fluid based on the surgery. It's around 4 ml per kg per hour for minor surgery or moderate surgery, and it is 8 ml per kg per hour for major or supra major operation like abdominal hysterectomy, Whipple surgery, and craniotomy. But the thing is that again, the not the amount is the optimum fluid is that the term is optimal and the adequate of what adequate fluid we have to give to maintain something. So what is the something? This is the monitoring. So monitoring volume status during the perioperative period with advantage and disadvantage. You have I don't know whether hemodynamic monitoring. This by this time you must all of you have read all these things. You know better than me. There is some static parameters. There is some dynamic parameters. Static parameters some advantage. There is more advantage in dynamic parameters, but both have some advantages and disadvantages too. So in static parameter like central venous pressure, pulmonary occlusion pressure, LVEDA, extra lung volume, all these things are there. In dynamic parameter, this is stroke volume variation, pulse pressure variation, and these things, and compressibility, IVC distendability index, and expiratory volume, tidal volume challenge test, all these are there. We have to go through this and we have to maintain, we have to give fluid according to fluid responsiveness state of the patient. Now, restrictive versus liberal strategy, what to give, liberal fluid or restrictive fluid. And there's a relief trial that occurs in 47 centers in 7 countries from May 2013 to September 2016 with 3,000 patients, major abdominal surgery, uh, 43% colorectal and 64% cancer, and restrictive surgery, that's mean no fluid prior to the surgery, 5 ml per kg during the induction, followed by 5 ml per kg per hour till surgery ends. For next 24 hours, they have given 0.8 ml per kg per hour fluid. Whereas in liberal strategy, they use 10 ml per kg during induction, 8 ml per kg per hour during surgery, and then 1.5 ml per kg per hour for at least 24 hours. So outcome, there is no difference in the rate of 1 year disability-free survival between the groups. But there is a higher rate of AKI in restrictive strategy. So this is the relief trial based on surgical patient. So same you must go through this classic trial, that is the septic patient from September 2014 to August 2015, Denmark and Finland. The ICU patient with septic shock. So isotonic crystalloid bolus of 250 ml to 500 ml during ICU stay with severe hypoperfusion. So what is the indicator of severe hypoperfusion? Lactate level more than 4, MAB less than 50, even on NORAD support, mottling score more than 2, oliguria of less than 0.1 ml per kg per hour for 1 hour. So they have given isotonic crystalloid bolus of 20 feet to 250 to 500 ml during ICU stay. In control, they have given standard treatment. Outcome, what they have found that less fluid in restrictive group, no significant difference in mortality and RRT. So, worsening of AKI is less in restrictive group. So, in this classic trial, that shows the restrictive strategy is better than liberal strategy. Fluid requirements in special situation, mainly surgical point of view. So neurosurgery patient is frequently receive diuretics in the preoperative period for reduction of the intracranial pressure and often have hypovolemia intraoperatively following blood loss. So all hypoosmolar fluid like 0.4% saline or 5% glucose in water cause reduction of the in plasma osmolarity. So besides glucose administration increase local and global ischemia leading to neurological damage. So salt-free solution containing glucose are better to avoid in this patient with brain and spinal cord injuries. During resuscitation of traumatic brain injury, hypertonic saline solution are useful in reducing ICP and maintain cerebral perfusion pressure without producing an osmotic diuresis. And normal saline is the preferred drug of choice for resuscitation in traumatic brain injury. Major cardiac surgery like cardiopulmonary bypass is associated with changes of many complex physiological and biochemical pathway, making volume replacement is complicated. The patient's underlying electrolyte and volume status must be reviewed before the choosing the fluid. So cardiac surgery volume management is complex, tricky, and critical. Potassium containing fluids must be avoided in presence of hyperkalemia. As we know, excessive crystalloid administration is associated with volume overload and pulmonary edema. Colloids, with exception of albumin, have disadvantage of causing coagulation abnormality and AKI. So we have to choose our fluid wisely and according to patient condition. Patient undergoing liver transplant surgery has end-stage liver disease, which is associated with low systemic vascular resistance, causing sodium and water retention by the kidneys. This increase in the amount of total fluid, but the presence of portal hypertension, there is a chance of ascites and pleural effusion also there. Preoperative coagulopathy is common and hemorrhage can occur at any stage of operation. So, therefore, any excess of fluid administration should be avoided during surgery and low CBP is desirable. The use of FFP and platelets and cryoprecipitate are commonly advocated to prevent coagulopathy and reduce risk of volume overload. During the surgery, we are discussing intraoperative things actually over here. Now, kidney. So, kidney transplant surgery, goal directed therapy or flow directed therapy based on trigger used for fluid administration in kidney transplant surgery. So, we have to cautious when these patients come into the ICU, we have to assess the volume status of the patient. We have to check the background disease condition. We have to check the other comorbidities, and then we have to choose our fluid and we have to transfuse accordingly. So, in conclusion, it is necessary to continuously monitor the fluid intake and output with the help of appropriate monitoring tool. There is no single monitor that performs best in all circumstances. Both restrictive and liberal strategies of fluid administration are useful in specific conditions. So, this condition is important. We have to assess the patient, we have to assess the clinical condition, and we have to treat accordingly. Both crystalloid and colloids can be used, uh, although former is preferred or latter as the first choice. So we can go for restrictive strategy, we can go for liberal strategy, we can go for crystalloid or colloid, but depending on the patient condition and the clinical scenario. So this is last topic, diuretic and kidney. Little bit I go through it. We know the classification of diuretic, carbonic anhydrase inhibitor, loop diuretic, phase diuretic, and potassium sparing diuretic. So it can come as a short note, diuretic in AKI. So what to do? What is the benefit of diuretic? What is the limitation? Benefits: control of volume overload. We know inhibiting tubular glomerular feedback, renal flushing, there is a reduction of the medullary oxygen consumption, prevention of tubular obstruction. Though there is some benefit of diuretic, there is some limitation to precipitation of intravascular volume depletion. So if we, prior to adequate volume resuscitation, if we give Lasix or any diuretic, and that can lead to intravascular volume depletion. Non-oliguric AKI, giving some diuretics that makes oliguric AKI to non-oliguric AKI, but may reflect underlying severity of the illness uh, to and delay the renal replacement therapy. A nephroprotective effect is not proved of Lasix or diuretics, and these critically ill patients usually have hypoalbuminemia. So the effect of diuretic is highly dependent on protein level, serum protein level. So effect may be not adequate. So we have to keep in mind too. This is a article published in JAMA 2002, Diuretic Mortality and Non-Recovery of the Renal Function in Acute Renal Failure. And this is the one of the trial that changed the practice of diuretic in AKI. And this comes as a negative result. Actually, this study shows the if you use diuretics in that associated with increased mortality, and there is a increased chance of renal and decreased chance of renal recovery and lead to renal failure. So this causes the today's confusion with diuretics in AKI. Later in 2009 to June to September 2009 to June 2014 in Canada and Australia, there is a SPARK trial, early phase of AKI, in the risk phase of Rifle criteria that we'll discuss later. Lasix infusion for 24 hours to 7 days, depending on situation. And they have found there is a did not change incidence of progression to worst degree of kidney disease. So it again it comes with the some positive result that we can give diuretic if it necessary. So now Lasix challenge test or fusemide challenge FST. It is the ideal functional tool to assess the renal tubular integrity in AKI. Fusemide is not filtered and thus its function is completely dependent on tubular function. The prerequisite, first we have to achieve adequate volume. Without achieving adequate volume, patient volume status, we can't give Lasix. So again, so first thing is that we have to adequately volume resuscitation to be done. Then IV furosemide 1 mg per kg in diuretic. If we give Lasix or furosemide in last 7 days, we have to give 1.5 milligram per kg dose. Or if we know first time we are using, then we have to give 1 mg per kg dose. If urine output after giving this, we have to monitor for 2 hours and we have to check whether it is more than 200 ml or not. If it is more than 200 ml, then we will call furosemide stress test is responsive or positive. So its subject is early AKI serve as a novel assessment of tubular function. So make it clear, furosemide stress test is for tubular function, assessment of tubular function. If works, that means renal tubule are still working. So it is implication to identify those patients with severe and progressive AKI, uh, FST, and the timing of initiation of renal replacement therapy. So some nephrologists use this as a initiation of renal replacement therapy. If FST is not responded, then we start the RRT. But there is no robust evidence regarding that. There is multiple small trial are there, but there is no good evidence for that. And still, the indication of renal replacement therapy are same as indication as I discussed in my first few slides. The furosemide response has been used to predict renal recovery and cessation of RRT in critically ill patient recovery from AKI. So again, whether patient is recovering for AKI, so whether patient need further uh, dialysis or not, that to be decided by Lasix challenge test. Again, there is no evidence, rather accumulation of furosemide can cause ototoxicity. So this is not implicated for that purpose too. Furosemide stress test is predicting delayed graft function in renal transplant recipient. That can, there is some study in that too. Patients with delayed graft function had significantly decreased urinary response to intraoperative furosemide. So this is the things, only these two, mainly the tubular function, whether tubular function is proper or not, that can help by furosemide testing, and it can also help the stages or staging of AKI can be done through this test. Not more than that. It does not change the mortality or morbidity or anything. So next is yeah. Biomarkers and diuretic responsiveness. So there is a multiple renal biomarker, kidney biomarker. You have must read this by this time, and Trishita will cover that biomarker in AKI later on. This is the thing about the diuretic responsiveness and biomarkers. So urinary spot sodium is the most important. The most of the diuretic causes natriuresis. Actually, the function of most of the diuretic is sodium and water excretion. They excrete sodium along with the water. So they cause the natriuresis. So there is excretion of sodium and water after using of diuretic. If urinary spot sodium level is remains below 50 to 70 milliequivalent per liter after 2 hours, then that indicates poor responsiveness to diuretics. And in vasopressin, that is, aquaporin 2, regulated by vasopressin, replace kidney collecting duct water permeability mechanism. Urine aquaporin 2 levels predict responsiveness to tall heparin. It's not diuretics related, but this also a marker that can come they can ask in practical exam. So newer markers that can predict the diuretic responsiveness, that is olfactomendin 4, and that is a secreted glycoprotein expressed in the neutrophils and stress epithelial cells, is upregulated in the loop of Henle, and particularly in AKI. Luminex immunoassay is used to measure this olfactomendin 4, and a higher olfactomendin associated lack of response to furosemide. So this is the thing, but this is not in day-to-day practice. This is in research level, and there's also some study that show the elevated baseline blood cystatin C is also associated with reduced diuretic response during heart failure treatment in hospitalization. So if there is a high baseline cystatin C is higher, there is a chance of diuretic resistance in patient with heart failure who are treating with diuretics. So last few slides are there, 1 to 2 slides. I'm taking little more time. Uh, Myths with loop diuretic. We have to clear in your mind prior to your exam, particularly practical exam, not only practical but also day-to-day practice. Furosemide does not resolve kidney impairment or it not prevent the need of RRT. Furosemide does not cause AKI and is not contraindicated AKI. So furosemide use is volume overload. If you have volume overload, if he has AKI, you can use. If it is not in volume overload, there is no need of furosemide. Continuous furosemide infusion does not improve outcome when compared to the intermediate IV bolus. We know it improves diuresis, but no outcome improvement is not there with continuous infusion. Another thing is, if serum creatinine level is increasing in combination with rise in PCV in patient on furosemide, that indicates effective decongestion rather than worsening of renal function. So in with day-to-day practice, we have seen after giving Lasix, there is an increase of creatinine. So it does not mean we have to stop the Lasix or furosemide. We have to that indicate there is a good decongestion. So we have to think prior to stopping furosemide whether it is uh, effect of furosemide or it is effect of good action, better response of furosemide. So we have to choose accordingly, decide accordingly. Another thing, albumin is furosemide. Albumin and Lasix combination we very much use in ICU. But why and how it works? Furosemide, as I told earlier, it is a highly protein-bound compound, protein-bound drug, and severe hypoalbuminemia is associated with impaired furosemide secretion in the tubular lumen. So, patient with hypoalbuminemia or administration of furosemide along with albumin can enhance diuresis. So it helps increase diuresis if we give Lasix along with the albumin, but it does not change the outcome. Patient with normal blood protein, this combination infusion does not show any benefit. So we have to give only you can give if patient having hypoalbuminemia, but there is no role of albumin and Lasix infusion in normal patient with normal blood protein level. That's all from my side. Thank you.
Thank you, Devottam. It was an extensive presentation, but it's required also. So he covered a lot of exam questions. CRRT, as we all know, is very important for AKI with multi-organ dysfunction for patients who cannot tolerate hemodialysis, intermittent hemodialysis. So for us to know as exam goers is we have to know about the indications and patient selection which he has covered, the different modalities of CRRT, and the key differences between CRRT, SLED, and intermittent hemodialysis is very important. How to prescribe CRRT, that also we covered with an example. Also, what should be the right dosing? Does standard dose versus higher dose actually make a difference? What does the evidence say? These points were covered, and we all should know this. And anticoagulation strategies, different anticoagulation strategies in different patients. What is regional citrate anticoagulation? These are the frequently asked questions. And also, how do you monitor a patient on CRRT? What parameters to look for, and how do you troubleshoot the most important problems which you encounter during CRRT? And CRRT in special situations is also important, and we should go through it, like CRRT in liver failure, CRRT in ECMO patients. How do you actually attach CRRT in ECMO patients? There are 4 different ways of attaching it. And drug dosing during CRRT, nutritional adjustment during CRRT. These are very important point for exam goers. So apart from that, after that, we actually covered about the perioperative fluid management and choice of fluid for resuscitation, the balanced salt and normal saline. And rhabdomyolysis can definitely come as a short note. So very important topics covered. Next, I would like to invite Dr. Trishita. She is also working as an associate consultant in Apollo Multi-Speciality Hospitals. She has just given her exam last year, and all the questions are fresh in her mind. So she was the right person to take these topics, and extremely hardworking, extremely studious, and I hope she will be a very good mentor to the exam goers who are going to give the DRNB exam this year. So over to you, Dr. Trishita.
Thank you, ma'am. Uh, is my slide visible?
Yeah.
Okay, ma'am. Good evening. After the extensive lecture given by Dr. Devottam, he has done his job very well, and I will be repeating some of his points and adding to it about the biomarkers. So we will carry it forward. So the first question, whenever you are answering, the better not to write in a descriptive manner, better to make tables or flow chart, which I will be showing in my answer, because descriptive, the examiners sometimes have to check a lot of copies, they become bored. So wherever possible, do a small diagram and give the brownie points attached to it. Always, it should not be a descriptive answer. So the first question will be AKI staging and classification. For AKI staging, first you have to write a definition given by the KDIGO guidelines, that is the standard. It is an abrupt, within 48 hours, decrease in kidney function manifested by an absolute increase in serum creatinine of more than 0.3 milligram per DL, a relative increase in creatinine of more than 50% from baseline, or a reduction in urine output less than 0.5 ml per kg per hour for more than 6 hours. So for writing this, you can write this description also, which is mandatory. Otherwise, you can make a table like this, which I have made. You can describe it: acute kidney injury, timing less than 7 days. What are the functional changes? The creatinine goes up to 1.5 times the baseline, or increase of 0.3 milligram per DL within any 48 hours, or the urine output which is less than 0.5 ml per kg for more than 6 hours. The structural damage is undefined in this definition. And then you can write the transition from AKI to AKD. AKD is, we tell, if when it is more than 7 days, 7 to 90 days, and when it is more than 90 days, that is more than 3 months, it goes to chronic kidney disease. Then I will come to the staging part. For the staging part, you should start with the Rifle criteria. That is the based on the GFR and the urine output criteria, the risk, injury, failure, loss, and the end stage renal disease. I won't be dictating everything because everybody will be knowing this Rifles criteria. It is an exam time. Most important part of this Rifles criteria is you have to write about the loss that is persistent acute renal failure, that is a complete loss of renal function more than 4 weeks, and end stage renal disease, that is you have to highlight these points. And when you are writing the Rifles criteria, you should always mention the pitfalls in the Rifles criteria which laid weight to the Akin and the Kidigo guidelines. The Rifles criteria signals its presence when there is already has been a greater decline in the GFR. Diagnosis could not be made at an early stage. It could not distinguish between the different etiologies. Urine output criteria rely only on the hourly measurements and can be altered by the use of diuretics. Baseline creatinine was not available. Assume normal GFR or a steady state level. Small increase in creatinine levels inducted a poor outcome. Urine output and creatinine criteria are unbalanced. So this gave way to the Akin criteria, the Akin and the Kidigo guidelines. So the Akin, there is stage 1, stage 2, stage 3. Akin, when you will discuss about the Akin criteria, you will write serum creatinine 1.5 more than 2 times increase or more than 0.3 milligram per DL increase. It is any one of the criteria. Or urine output criteria less than 0.5 ml per kg per hour for 6 to 12 hours. If you compare the Akin and Kidigo, they are more or less a bit similar. The serum creatinine, this was given 1.5 to 1.9x increase. And then stage 2 crumbs, stage 2 to 3 times, or the urine output less than 0.5 ml per kg for 12 to 24 hours. Here also similarly 2 to 2.9. And stage 3, one of the following: the serum creatinine more than 3 times, or the serum creatinine increase in 0.5 milligram per DL increase, or baseline serum creatinine is increased more than 4 milligram per DL, or urine output less than 0.3 ml per kg per hour for more than 24 hours, or anuric for more than 12 hours. And in Kidigo, it was given as serum creatinine more than 3 times, serum creatinine more than 0.3 milligram per DL increase, serum creatinine baseline increase of 4 milligram per DL, urine output decrease of 0.03 ml per kg per hour for more than 24 hours, or urine output there is anuria for 12 hours. Then you have to discuss about the pitfalls in the Akin criteria also. When there was a comparison between the Rifle and the Akin criteria, there was no difference in the predictive acuity between these two systems. The 48-hour window period for AKI diagnosis may miss patients with a slow but significant increase in creatinine. Issues related to urine output criteria still remain. Then for Kidigo pitfalls, you have to discuss about the limitation of the creatinine. Because it is a creatinine based method, you have to write creatinine is a late marker of decreased GFR. Creatinine is an insensitive marker in normal and high GFR ranges. Kidigo criteria requires a baseline creatinine, assuming GFR 75 ml per minute per 1.73 meter square when unknown. Creatinine is a marker of kidney function. It is not a marker of kidney damage. Defining AKI by Kidigo does not provide insight into the etiology or the pathophysiology of AKI. Then there is limitations of the urine output paste criteria also. Urine output criteria lacks specificity. Obese patient weight-based urine output criteria is often misleading. European renal best practice guidelines recommend using ideal body weight. Decision to initiate RRT classifies the patient is in stage 3. But however, there are some emergent indication of RRT in AKI, which are variable. Kidigo criteria is less useful for evaluation of renal recovery. Now then, coming to the next part of the question, I have to discuss about the staging and the classification. Before discussing about the classification, you should write shortly about the risk factors for AKI. What are the environmental, that is insufficient water, poor water disposal, sanitation condition, increased risk of infections. What are the patient-related age, comorbidities, diabetes, any cardiac elements or liver disease, any underlying infection, exposure to toxin and drugs. And in developing countries, there may be obstetric complication, infection, sepsis, and any venoms, the snake bite, scorpion bite, anything. Then etiology is multifactorial in critical ill. There are some baseline risk factors which I have mentioned earlier. Then it leads to acute conditions, that is sepsis, hypotension, volume depletion, any rhabdomyolytic condition present, any cardiovascular surgery, any major abdominal surgeries where there may be fluid loss, third spacing which has been discussed by my colleague, any abdominal compartment syndrome or mechanical ventilation, and ultimately the nephrotoxic part induced by the contrast media, antimicrobial agents, chemotherapy, NSAIDs, immunosuppressive agents, myoglobin, or any free heme. So for discussion, for this, you can divide it, you can draw a diagram, and you can discuss about the pre-renal AKI, the factors you can give in a, what are the causative agents of the pre-renal AKI, intrinsic renal AKI, and the post-renal AKI. So for the pre-renal AKI, you can make a table also. What is the cause when there is reduced renal perfusion, which might be due to volume depletion, any renal loss due to diuretic osmotic diuresis, or there might be extra renal loss due to vomiting, diarrhea, skin losses, hypotension, cardiovascular causes, hemodynamic causes, any use of radiographic contrast, or induced by this lots of drugs which may inhibit the prostaglandin synthesis by the NSAIDs. Then there may be toxicity by the cyclosporine tacrolimus, ACE inhibitors, ARB, amphotericin B, hypercalcemia, hepatorenal syndrome also induces a pre-renal AKI condition and abdominal compartment syndrome. Then coming to the intrinsic causes, you can divide into the vascular causes, tubular causes, glomerular causes, and the interstitial causes. And then the post-renal acute renal failure obstructive part, that is the prostate hypertrophy, neurogenic bladder, any intrauterine obstruction, extrauterine obstruction. You have to divide it in a very meticulous manner, make tables whenever you are answering. So it will be give you additional marks. Then before ending this question, you have to write the differences between how to distinguish between pre-renal and renal AKI. For pre-renal AKI, the history part, you have to account for any urinary, skin, volume, blood loss, or any third spacing present. And for renal, any drug or toxin exposure or any hemodynamic changes. In clinical presentation, there might be presence of hypotension or volume depletion in case of pre-renal AKI. And in ICUs, we get a lot of cases of any GI loss there, which may be associated with any acute gastroenteritic cases. Diarrheal cause is one of the most common causes of AKI in ICU. No specific symptoms or signs in renal AKI. Then the laboratory parameters you have to account for. You have to see the bun and serum creatinine ratio, which is more than 20 in case of pre-renal, less than 20 in case of renal. Then the sediments are no cast in pre-renal, and you find the muddy classic muddy brown cast in renal AKI. Then the urine osmolality is more than 500 in pre-renal, and in renal it is less than 350. Proteinuria might be present from none to trace in pre-renal, and it is mild to moderate in renal. Then urinary sodium is less than 20 and more than 40 in renal. Fractional excretion of sodium, which is an important parameter, is less than 1%, and it is more than 1% in renal. Fractional excretion of urea percentage is less than 35 in pre-renal, more than 35 in renal. Then the urine creatinine to serum creatinine ratio is less than 20 in pre-renal and more than 40 in renal. And then can be use of the biomarkers for diagnosis of renal AKI. Now, coming to the next question, it is a 5-mark question about the biomarkers. But before starting the question, you have to discuss, which I have discussed in the earlier part also, what are the pitfalls of serum creatinine and the urine output, which is nowadays giving way to the use of biomarkers for diagnosis of AKI. We all know that serum creatinine is insensitive to kidney damage. It is affected by exogenous creatinine intake, dependent on the muscle mass, metabolism, liver function, influenced by physiological and analytic variability, can rise without true renal dysfunction because there may be drug-induced tubular secretion due to cimetidine or trimethoprim, hemoconcentration during diuresis, and it is altered during the pregnancy. And the urinary output is also not a reliable measurement because transient oliguria may be physiological, can be manipulated by the use of diuretics, prone to measurement error even in use with catheter use. The catheter might be blocked, or some sediments might be there, so it is a confounder in that factor. So the acute disease and the quality initiative group in 2020 proposed the use of biomarkers to diagnose AKI with kidney damage even in the absence of renal dysfunction. So the proposed new definition of acute kidney injury can be given in this manner. Basically, it is adapted from the KDIGO, but they have divided into 1A and 1B. The stage 1, 2, 3 remains, but generally they divided if there is no change in serum creatinine or less than 0.3, but the biomarker is positive, it is subclinical 1S stage they divided. And in increase in serum creatinine is there, and it is falling in the stage 1. Then if the biomarker is negative, they divide it into 1A, and 1B is if the biomarker is positive. Similarly, in increase in serum creatinine by 200% or the urine output less than 0.5 ml per kg per hour for more than 12 hours. If the biomarker is negative, it is 2A, and if the biomarker is positive, it is 2B. If the increase in serum creatinine level by 300% or an absolute increase in absolute value is more than 4 milligram per DL with an acute increase in 0.5 mg per DL or urine output less than 0.3 ml per kg per hour for more than 24 hours or anuria for 12 hours or there is initiation of any renal replacement therapy. The biomarker is negative, it is 3A, and the biomarker is positive, it is 3B. So it is basically a modification which we have studied in the AKI staging with biomarker negative and positive. The negative part, to remember, negative part is always given in A, denoted by the A, and the B sequence is for the positive part. So whenever you are writing about the biomarker, please make a diagram and write, and it is a very easy diagram you can make, just pointing about the functional stress markers and the damage marker. And even you can in the functional marker, which is the secreted by the plasma, and what is the urinary marker, and amount the damage, what is the plasma marker. So what are the stress markers indicate? It indicates the cell stress. Cell stress can resolve or progress to damage or alter kidney function. The damage marker is the structural damage with or without reduced kidney function. The constitutive proteins released by damaged kidneys, molecules upregulated in response to injury, or non-kidney tissue products that are filtered, reabsorbed, or secreted by the kidney. And the functional markers generally reflect the changes in the glomerular filtration. So this diagram is very easy. You can make and distinguish between the markers. Whenever you are writing, just remember these important biomarkers because there are a lot of biomarkers, but these are the main biomarkers you have to write to get at least passing marks. This table is very important. At least you can get 3 out of 5 if you mug up this table. You will write about the tissue this is one of the most important, that is nephrocheck, tissue metalloproteinase 2, insulin-like growth factors binding protein. What is the type where it is secreted in, where you find it is a urinary marker sample. It is a stress marker. The appearance and peak after injury is immediately after exposure and peaks at 6 to 12 hours. It is a functional role in kidney, is a cell cycle arrest, and it has a protective mechanism. Then NGAL is one of the most important marker. It is also urine, or you can also find it in, it is a plasma marker. It is basically a damage marker. Appearance is less than 4 hours after injury and peaks at 4 to 6 hours. The functional role is induces genesis of tubular epithelium or anti-inflammatory and anti-apoptotic role it has. Then third comes the kidney injury, one marker, mainly a urinary marker. It is a damage marker. It appears at 12 to 24 hours, peaks at 2 to 3 days. It signifies renal recovery, tubular regeneration, clearance of apoptotic bodies, anti-inflammatory effect. Then cystatin C, urine serum. It can be found in the plasma also and in the urine. It is a functional marker. His appearance is it is a filtration marker. Then there is proencephaline. It is a serum marker. It is a functional marker and it is a filtration marker. Then for getting more marks, write detailed about this NephroCheck test. It is only FDA approval. This is NephroCheck consists of these two biomarker, that is a TIM2, tissue metalloproteinase 2, and insulin-like growth factor binding protein 7. Metalloproteinases are released during cell cycle arrest. This is a stress marker reflecting cellular stress that precedes tissue damage. FDA approval for prediction of AKI stage 2 and 3 within 12 hours in critically ill patient with cardiac and respiratory failure. So it can be used in prediction, diagnosis, and severity of AKI. Then you have to discuss a bit about NGAL also. It is a 25 kilodalton protein covalently bound to gelatinase of neutrophil, produced by neutrophil and tubules mainly in the thick ascending lip and the collecting duct. It is a damage marker. It is a marker of tubular inflation. NGAL is detectable in urine 2 to 3 hours after an ischemic or nephrotoxic insult. Plasma NGAL also increases in AKI. Role in diagnosis of AKI and assessing the severity of AKI is done by NGAL. Then comes cystatin C. It is a 13 kilodalton protein cysteine protease inhibitor produced at a constant rate by all nucleated cell and released into plasma. It has a small size and positive charge makes it freely filtered at the glomerulus. Cystatin C is reabsorbed and almost completely catabolized in proximal tubular cells. It is a functional marker. Renal tubular cells take up the cystatin C and cannot be measured in urine. Plasma cystatin C is used to estimate the GFR. Presence in urine signifies tubular injury. It has a role in diagnosis of AKI and assessing the severity of AKI. So there are many limitations of biomarkers also, which you have to mention along with the table which I have discussed. NGAL is elevated in sepsis, CKD, and UTI also. KIM1 is elevated in chronic proteinuria and inflammatory diseases. The fatty acid binding protein is elevated in anemia, and this TIM2 insulin growth factor binding is elevated in diabetes. Then the next question is about contrast induced AKI. It is caused by iodinated contrast medium. Previously, it was known as contrast-induced nephropathy. The clinical criteria for diagnosis of contrast-induced AKI is there should be an exposure to contrast, increase in serum creatinine by 0.5 milligram per dl or 25% from the baseline within 24 to 48 hours of exposure to contrast. It peaks in 2 to 5 days. Alternative diagnosis should be ruled out, like that intravascular volume depletion or AIN due to hypersensitivity due to contrast medium. It usually recovers in less than 1 to 3 weeks. So for writing the contrast, the induced this AKI, you have to write about the risk factors. There may be, these are the proven risk factors for contrast-induced AKI. This may be patient-related risk factors, which might be modifiable, which is anemia, hypotension, volume depletion, hemodynamic instability, use of drugs, that is NSAIDs, diuretics, and other nephrotoxic drugs, ACE inhibitors or ARB use, acute heart failure, hypoalbuminuria, periprocedural hypoglycemia, and some unmodifiable risk factors. There's presence of chronic kidney disease, diabetes mellitus, age more than 70, acute coronary syndrome, CLIP 3 to 4 grading, procedure related risk factors, femoral approach, repeated exposure of contrast media within 72 hours, volume of contrast media, emergent or urgent procedure, or any IBP use. For the pathophysiology of contrast induced AKI, you have to write, you can make this flow chart. You have to write exposure of contrast medium. There are two mechanisms. One is the cytotoxicity leading to endothelial damage and tubular injury, which leads to generation of the reactive oxygen species. And this all things leads to vasoconstriction, which leads to medullary hypoperfusion, and which in turn leads to medullary ischemia and decrease in glomerular filtration rate, and the viscosity increase in the viscous part. The using a high ionic contrast is there is always an increase in the viscosity, which leads to decrease in tubular flow, decrease in medullary perfusion, which in turn leads to medullary ischemia and glomerular filtration rate. Then there are features of contrast induced AKI. The increase in serum creatinine is usually early and mild and typically starts to decline towards baseline within 3 to 7 days of exposure to contrast. There will be non-oliguric AKI. Urinary sediment consists with acute tubular necrosis, muddy brown granular and epithelial cell class, and free renal tubular epithelial cell. Absence of this urinary findings does not exclude the possibility of contrast-induced AKI. The preventive measures for contrast-induced AKI, you have to use non-ionic low osmolar to isoosmolar is preferred to any high osmolar agents, because any increase in viscosity of the agent will lead to decrease in the medullary perfusion, which in turn leads to the medullary ischemia. KDIGO 2013 latest guidelines use of low osmolar or isoosmolar rather than high osmolar contrast agent. No reliable evidence to base a recommendation for either low versus isoosmolar agents. Now, most commonly used agents are low osmolar non-ionic contrast agent or isoosmolar contrast agent, specifically idoxinol. This is the 2018 guidelines on in this myocardial revascularization. It was given you should use of low there should be use of low osmolar or isoosmolar contrast media, and the volume of contrast media should be minimized. The total contrast volume by GFR should be less than 3.7. And this 2021 guidelines given by the ACC, AHA joint and the SKY guideline for coronary artery revascularization also summarizes the best practices in catheterization of laboratory for patient with CKD undergoing angiography. Here, if you see, you have to administer adequate procedural hydration, record the volume of contrast media administered, and minimize the contrast use. And there is also a recommendation of pre-treatment with the statin and use of radial artery if feasible. They do not recommend the use of NAC to prevent contrast-induced AKI. And no role of prophylactic RRT in this scenario, which is very important. So the recommendation is the KDIGO recommends IV volume expansion with either isotonic normal saline or sodium bicarbonate rather than no IV volume expansion in patient at increased risk. The CIM, the 2017 guidelines recommend correction of hypovolemia and dehydration using isotonic crystalloid in patient receiving intravascular contrast media. Our ICCM guidelines made no recommendation in this fact. They only told euvolemia to be ensured. What is the role of oral or IV hydration? KDIGO recommend not using oral fluids alone in patients at increased risk of contrast induced AKI. The NICE guideline have recommended oral hydration not considered inferior to IV hydration at preventing contrast-induced AKI. They recommend oral hydration before and after contrast exposure in adults. Consider intravenous volume expansion if they are at particularly high risk. For example, if eGFR is less than 30 ml per minute per 1.73 meters square. In renal transplant patient, large volume of contrast being used and repeated administration within 24 hours. And if there is use of intra-arterial contrast. Then about the role of hemofiltration and hemodialysis, contrast media, water soluble, less protein bound. So the idea is it is excreted exclusively by kidneys through glomerular filtration. Single session of HD removed 60 to 90% of the contrast, but studies have shown no benefit from these modalities. Though there is a theoretical advantage given in this mechanism, but the studies have shown no benefit from these modalities. The proposed reason might be delayed timing of HD since renal hyperperfusion noted within 20 minutes of contrast administration. During first renal hemodynamic passage, rapid release of free oxygen radicals. So the KDIGO guidelines suggest not using prophylactic intermittent hemodialysis or hemofiltration for contrast media removal in patients at increased risk of contrast-induced AKI. Then any role of NAC? The mechanism proposed is exposure to contrast media. There is increased production of reactive oxygen species. Then there is lipid peroxidation and intracellular protein degeneration. And NAC acts as a free radical scavenger, anti-oxidative and anti-toxicity effects, inhibits angiotensin converting enzyme activity, decreases angiotensins, induces endothelial nitric oxide enzyme expression. But though KDIGO suggests using oral NAC together with IV isotonic patient at increased risk of contrast-induced AKI, the ESCIM guideline does not suggest NAC to prevent contrast-induced AKI in critically ill patient because of conflicting results and possible adverse effects. The ICCM guidelines, no recommendation has been made, only euvolemia to be ensured. Then any role of statins? We know that statin has direct renoprotective effects, inhibits the tubular uptake of contrast media, limits the inflammatory, oxidative, and the apoptotic process. It has the pleiotropic effects that it acts as an antioxidant, antithrombotic, and anti-inflammatory. But KDIGO has no recommendation in this matter. The ESCIM guidelines suggest a short-term use of atorvastatin or rosuvastatin to prevent contrast-induced AKI in high-risk patient undergoing coronary contrast angiography. The ICCM made no recommendation. So this part of contrast-induced AKI, you have to write about the recommendation. Mainly, if you forget about this recommendation, which committee made which recommendation, make a table what that NAC should be. According to the recent practices, only hydration by IV or oral fluid is the key to prevent any contrast-induced AKI. There is no recommendation of NAC or any RRT, though some societies recommend the use of statins because of its pleiotropic effects. So you can write the cross points if you forget about which committee, which society made which guidelines, what are the recommendation. And you should write about the pathophysiology and what is the definition of contrast-induced AKI. 5 marks will be enough. So this is a debatable topic, timing of RRT. So the timing of initiation of RRT, optimal timing of RRT in critically ill patients with AKI is still debatable. Numerous observational studies and RCTs have been demonstrated to decide upon early versus late initiation of RRT. I will be discussing about AKK Elan Idle ICU, AKK2 Start AKI trials. other major I will be discussing about each of these trials, but in the last I will be showing you a table. If you forget about each of this trial, study about this table which I will be showing you in the last, which will, if you write this, I think you will get good marks. But first, before writing this answer, always mention what are the rationale for for initiating early initiation of RRT. What are the advantages actually? That is prevention of severe electrolyte and acid-base imbalances, better volume management, prevention of uremic complication, recovery of distant organ injury, and prevention of early AKI-induced impact to vital organs such as heart, liver, lung, brain, and liver, resulting from electrolyte metabolic imbalance, fluid overload, and systemic inflammation. Now, each of the trials I will be discussing. First, I will be starting with Akiki trial. For the criteria for early RRT was within 6 hours of the stage 3 of the Kidigo AKI, started at median of 4.3 hours. And the late RRT was only on emergency indication, 51% received, the median was 57 hours. So the conclusion in a trial involving critically ill patient with severe acute with AKI, we found no significant difference with regard to mortality between an early and a delayed strategy for the initiation of RRT. It showed a delayed strategy averted the need of RRT in an appreciable number of patients. Now we come to the ELAN trial, which is one of the positive trials. But the negative part is it a single center randomized clinical trial. So the intervention early was started within 8 hours of diagnosis of kidney stage 2, and a delayed was within 12 hours of stage 3 of AKI. There was initiation of RRT. The primary endpoints were mortality at 90 days after randomization. What were the conclusion among the critically ill patient with AKI? Early RRT compared with delayed initiation of RRT reduced mortality over the first 90 days. But further, it has a caveat to it. Multicentric trials of this kind of intervention is warranted. Then comes the ideal ICU trial. The early RRT was suggested within 12 hours of failure stage of the AKI according to the Rifle criteria, and the delayed RRT was delay of 48 hours post diagnosis of failure or emergency indication. The conclusion was there was no significant difference in overall mortality at 90 days between patients who were assigned to an early strategy for initiation of the renal replacement therapy. Then comes the START AKI trial. The early was the RRT initiation within 12 hours of randomization, and the standard group was discouraged from initiating RRT unless of emergency indication or persisting AKI, that is more than serum creatinine more than 50% of the baseline. The conclusion was an accelerated renal replacement strategy was not associated with the lower risk of death at 90 days than the standard strategy. Then comes the AKK 2 trial. It has the inclusion criteria of severe AKI stage 3 Kidigo until oliguria persists for more than 72 hours or burn more than 112 milligram percentage. There was a delay strategy. RRT initiation within 12 hours. It is, in this case, it is the early one. RRT initiation within 12 hours of randomization, and a more delay strategy, RRT initiation post-mort till emergency indication or until burn more than 140 milligram percentage. So the interpretation was in severe acute kidney disease with oliguria more than 72 hours or a burn higher than 112 milligram per DL, and no severe complication would mandate immediate RRT. Longer postponing of RRT did not confer any additional benefit and was associated with potential harm. So this is a table which I was talking about. It has all the trials. You can mug up this table. It is a very difficult table, but you should remember that the only positive among this in ELAN was the ELAN trial, but it was a single center study. If you see, this is the highlight point of this ELAN trial. And all the other, when there was no difference in the mortality. So what does the KDIGO 2012 guidelines suggest? Initiate RRT when life-threatening changes in fluid, electrolyte, and acid-based balance exist. Consider broader clinical context rather than a single burn or creatinine value when making decision to start RRT. Our ICCM guideline, RRT should be initiated urgently in those who meet the criteria of absolute indication. For non-urgent indication, RRT should be considered when the capacity of the kidney cannot meet the metabolic demands imposed by AKI. So, for the optimal timing, evidence-based studies give us the confidence for expectant management in AKI. Expectant management can be practiced up to 72 hours unless life-threatening conditions develop. Should also be vigilant to provide best chances for recovery. Decision for RRT initiation is based on individual patient. Physician role plays a central role in decision for expectant management. You can make this flowchart. You have to monitor and reassess the illness trajectory, the AKI trajectory, response to resuscitation, development of complication. If there is any new or urgent indication or medically refractory complication of AKI, if there is presence, yes, then start RRT. And if there is no persisting or non-resolving severe AKI, there is progressive fluid accumulation or overload, worsening of metabolic profile. There might be presence of acidosis or electrolyte imbalance, worsening of azotemia, uremia. Consider relative balance of benefit versus risk versus benefit for initiating of RRT. So it is according to the clinician's purview to start RRT. So coming to the next question is about the use of USG actually. The next part will be renal resistive index. What is the background for renal resistive index? We know that there might be vascular dysfunction plays a vital role in the pathophysiology mechanism of septic AKI. So renal Doppler ultrasound can measure the renal resistive index, which is a sonographic index that reflects alteration in the blood flow profile of the intrarenal arcuate or interlobular arteries, allowing us to explore kidney hemodynamics non-invasively. So what is RR, renal resistive index? It is basically the measurement of the peak systolic, that is this systolic peak you can see, minus the end diastolic velocity divided by the peak systolic velocity. That gives you the renal resistive index. So why do we measure as only the interlobar artery? The reason is as the resistance to the blood flow progressively increases from hilar artery towards more peripheral parenchymal arteries, it is generally recommended that sampling for RRI should be done at the level of arcuate or interlobar arteries adjacent to the medullary pyramids. Measurement should be preferentially be repeated in different parts of both organ, that is superior, median, and lower. And when at least 3 values should be obtained, the mean value of 3 measurement at each kidney is usually considered. The method of Doppler is you should use an ultrasound machine with 2 to 5 megahertz curved multi-frequency transducer. Doppler signal should be obtained from 2 or 3 representative arcuate arteries at the level of corticomedullary junction. The P systolic Vmax and the end diastolic V minimum are determined by the pulse wave Doppler. So RRI, I have shown that in the earlier slide, Vmax minus Vmin, that is the peak systolic minus the end diastolic velocity divided by the peak systolic. So why does RRI increases in AKI? Because in AKI, there is tissue swelling, increase in intracapsular volume, which leads to the intracapsular pressure, which ultimately leads to increase in the renal resistive index. Now, this table is important. You have to make a table and write what does the value, what is the normal value of RRI. The normal value of RRI 0.5 to 0.7. If there is values greater than 0.74, there is 3.3 times risk of developing AKI at day 5. And if the value is more than 0.8, it shows persistent AKI. If the value is less than 0.71, it might indicate a transient AKI. So despite its relatively low specificity in terms of clinical pathological correlation, and still its poorly understood pathogenesis, RRI has been fruitfully used to gain diagnostic and prognostic insights into a variety of clinical condition, from renal vascular disease to CKD and renal transplant patient. In patient with renal artery stenosis, an RRI more than 0.8 has been shown to be a reliable indicator of poor therapeutic response to revascularization treatment. In renal transplant patient, increased RRI has been shown to correlate with the severity of vascular and interstitial damage and is a powerful predictor of disease progression. Increased RRI has been shown to be a marker of renal and extrarenal organ damage in primary hypertension. On basis of these results, the evaluation of RRI should be used to complement other signs of renal abnormalities in assessment and management of patient with primary hypertension. Evaluation of RRI may also carry therapeutic implication in elderly, helping protect kidneys by achieving a target blood pressure. Because if the diastolic from the formula it is evident, if the systolic increases and the diastolic decreases, the RRI will increase. So you have to target a map where there is less decrease of the systolic. You have to protect the diastole of the heart also. Like the next question is on VEXAS. So what is the background for the VEXAS study? Because elevated right atrial pressure from fluid or pressure overload leads to systemic venous congestion, impaired lymphatic drainage, and tissue edema. This congestion increases the organ afterload, contributing to complications such as hemodynamic AKI, congestive hepatopathy, interstitial congestion, edema, and delirium. Since physical examination is often reliable, VEXAS is emerging as an essential bedside tool. So what is VEXAS? VEXAS is actually venous access ultrasound grading system. It takes account into the first step is the IVC ultrasound, then comes the hepatic vein Doppler, then comes the portal vein Doppler, and last the intrarenal vein Doppler. So VEXAS assessment requires an ultrasound system with 2D imaging and Doppler, both color and pulse wave capabilities, using either a phased array or a curvilinear transducer depending on the patient habitus. An ECG module is recommended. ECG module is must for a VEXAS study, but otherwise it will be very difficult to understand S and D wave. For simultaneous ECG tracing with Doppler waveform to improve accuracy. Indication of VEXAS is, you can write make a table to write this. Suspected volume overload, which helps to assess the systemic venous congestion. Heart failure, it evaluates venous congestion and cardiac filling pressures. In AKI, basically it detects the congestion and contributing to the renal dysfunction. In shock stage, it provides insights into the hemodynamic status. Unexplained hypotension, it assists in identifying underlying congestion. In VEXAS, an IVC maximal of 2 centimeter of less than 2 correspond to VEXAS grade 2. But it is basically, the study was done by Philip Rolla in the Western population. So their cutoff was 2. But nowadays studies are being going in other population also, whether to proceed we can proceed even if the IVC in our Indian population is basically less than 2. If it is more than 1.7 to 1.8, you can very well proceed with the next steps of VEXAS, because there are conditions where you might find congestion. This is for the practical purpose I am telling, but for the theory purpose, if you write it is less than or equal to 2, correspond to VEXAS grade 2, but in practicality, I generally proceed if it is also less than 2. So for hepatic, then the hepatic vein should be examined. The IVC generally examined in the subxiphoid view. A phased array probe is often the easiest, but a curvilinear probe works well as well. Then we have to put basically if we find there is the IVC hepatic vein junction, at that junction you put this Doppler and you find the S and D wave. But tricuspid regurgitation is a confounder. The S wave has to be correlated with the ECG. The S wave occurs just after QRS. So ECG lead are must for doing a VEXAS. Then for the portal vein, the mid-axillary region line in the right side with the probe longitudinal or the at the right costal margin is used. A curvilinear probe is used. The flow moves towards the probe, that is red. Normal flow is continuous. If the flow becomes pulsatile, it indicates back pressure. Then for the renal artery, which is one of the most difficult to get in vexus, sometimes you have to tell the patient to hold the breath or apnea is given. So renal artery, this can be get in the vexus. A curvilinear probe is used with the abdominal preset is used. A Doppler, color Doppler is applied to find the vessel. A vessel is selected and the pulse wave is applied. Before discussing, I will discuss about this different waveforms which you get in vexus. Grade 2, I have told you, you have to make this table basically before in writing a question of vexus, because this table is extremely important in writing of vexus, because you have to show in a diaphragm what you mean by S and D waves, what is the pulsatility, and what is the intrarenal, what is diastolic reversal, and everything you can explain via this table. This is one of the most important diagram, I must say, in drawing of vexus. For vexus grading, grade 0, no congestion when the IVC is less than 2. This is basically in the Western population. For grade 1, there might be presence of mild congestion when the IVC is greater than 2 centimeter plus any of the combination of normal or mildly abnormal waveform is regarded as grade 1. Grade 2 is moderate congestion, IVC more than 2, plus at least one severely abnormal pattern. This is a severely abnormal pattern. This is a mildly abnormal pattern. This is the normal pattern basically. This is the mildly abnormal pattern. The normal pattern is S is greater than D. Mildly abnormal, S and D might become equal, or S or D is slightly greater than S. And the severely abnormal pattern is there is reversal. And then in portal vein, the pulsatility less than 30 is the normal pattern. It when within 30 to 50, it is mildly abnormal, and in severely abnormal, the pulsatility more than 50%. In renal, the continuous flow of the venous is the normal pattern, and if S and D waves are present like this, then it is a mildly abnormal pattern. And if there is systolic reversal, this is the grade 3, that is severe congestion. For grade 3 severe congestion, or you have to get IVC more than 2 centimeters plus 2 or more severely abnormal waveforms. Then you determine it as grade 2 vexus. This basically I have written this in a tabular form. You can write this table and then draw this diagram, then that can fetch you marks. The same thing which I have discussed earlier, this is the, because explanation of this diagram was easier, I have written this in a tabular form. What does the severe mean? What you have to basically, before writing also, you have to define definitions of the severe Doppler abnormalities. If you explain, the examiner might know that you are knowing about what is S wave, what is D wave. And then you will, after writing all this, you can write about the caveats of vexus, hepatic, that what are the pitfalls basically, what are the hepatic venous Doppler might be altered in tricuspid regurgitation or right ventricular dysfunction independent of the congestion. So there might be a reversal also, which might not always lead to your this is one of the disadvantages in cases of TR or right ventricular dysfunction. Then intrarenal vena Dopplers may be affected by respiratory mechanics, mechanical ventilation, or intra-abdominal pressure. Portal vein pulsatility may increase in condition unrelated to congestion, that is in severe liver disease or cirrhosis. Then this if you write, then you might get 5 marks. If you write it properly, this is basically a 5 marks question in an exam. You have to draw and explain via table, that will give you marks. Then the last question for the series is the explanation of the cardiorenal syndrome. It is one of the important organ crosstalk with cardiac with the kidneys. So cardiorenal syndrome encompasses a spectrum of disorder involving both heart and kidney, in which acute or chronic dysfunction in one organ may induce acute or chronic dysfunction in the other organ. It represents the confluence of heart-kidney interactions across several interfaces. So for the definition of this is cardiorenal syndrome, you have to make this table, which is the classification of CRS based on the consensus conference of the acute dialysis quality initiation. So for there is different phenotyping done 1 to 5. First is the 1 and 3 are mostly the acute one, and 2 and 4 is the chronic one, and 5 is the metabolic one. 1, this is the acute CRS, where the heart leads to the kidney, heart failure leading to AKI. Type 2 is the chronic CRS, that is the chronic heart failure resulting in CKD. The type 3 is acute again is the acute one, this is acute kidney injury resulting in heart failure, acute heart failure. Then type 4 is the chronic renocardiac syndrome, that is the CKD resulting in chronic heart failure. And type 5 is the secondary CRS, there is systemic processes resulting in heart failure. The systemic causes can be sepsis, amyloidosis, cirrhosis. Then for pathophysiology, better to write in a flow diagram rather than writing in a more descriptive manner. So for the pathophysiology, first I will discuss about the CRS type 1, where the acute heart failure, you can make this, what is the iatrogenic cause? There is RAS activation, there is sympathetic system activation, humoral signaling, there is increase in humoral signaling, there is increase in CVC, venous congestion, decrease in cardiac output, which in turn leads to decrease in water excretion, sodium excretion, increase in vasoconstrictive state. Then there is oxidative stress damage, cytokine secretion, decrease in renal pressure gradient, decrease. Ultimately, there is decrease in renal perfusion, and all this pathophysiology leads to reduced renal blood flow, reduced GFR, necrosis, apoptosis, tubular cell toxicity, and this leads to the acute kidney injury. So this can be made in a diagram plus flow chart manner. You can simplify in your manner, but basically if you draw a heart and kidney and then write this, do this in a flow diagram. Then type 3, here the acute kidney injury leading to acute heart failure. Here there is decrease in GFR, increase in RAS activation, sympathetic activation, humoral signaling, there is electrolyte disbalance, acidemia, coagulation imbalance. All this is leading to the RAS activation is leading to the decrease in water excretion, sodium excretion, increase in vasoconstriction, oxidative stress, cytokine secretions, arrhythmia, ischemic insult, which in turn leads to increased preload and afterload, decreased contractibility, pulmonary vasoconstriction, decreased cardiac output, ultimately leading to this acute heart failure. Then this is pathophysiology of the cardiorenal syndrome type 2, where the chronic, basically both are same, only chronic heart failure, there is altered sensitivity to the vasodilator factors, ANP, BNP. BNP is one of the most important cardiac markers for any heart failure patient. There is increase in RAS activation, sympathetic nervous system activation, humoral signaling, accelerated atherosclerosis, microvascular and macrovascular changes, repeated insults to kidney, increase in CVP, venous congestion, endothelial damage. So these things are leading to vasoconstriction, oxidative stress, cytokine secretion, decrease in renal pressure gradient, ultimately decreasing to the perfusion, leading to the chronic kidney stage. Then then cardiorenal syndrome type 5, there are systemic diseases, which are many, that is diabetes, amyloidosis, vasculitis, sepsis, sarcoidosis, cirrhosis, which is in turn, there is a crosstalk basically between all the organs. There is multifactorial involvement of then there is activation of the sympathetic nervous system, RAS activation, endotoxin in sepsis, there is endotoxin, LPS associated damage, there is a activation of the DAMs and PAMs, monocyte activation, oxidative stress, inflammation, exotoxin, toxemia, antibiotics, contrast, everything is leading to this hemodynamic changes, hypoperfusion, decrease in perfusion pressure, increase in SVR. Ultimately, there is organ damage. There is into the heart, impaired microcirculation, hypoperfusion, myocardial depression factor, myocardial hypoxia, ischemic insult, and then there is the damage to the kidney, reduced renal perfusion, acute tubular necrosis, septic interstitial nephritis, renal hyperemia, glomerular microthrombi also because of the DIC might lead to kidney damage. So these are the biomarkers. There are biomarkers. This table, whichever is very difficult to remember, I know, but important biomarker you have to write about the BMP. Then troponins you have to write, which is the important and identification and what is the prognostic value, and the important kidney biomarkers, serum creatinine and cystatin C, albuminuria, and the noble biomarkers. Write about, you have already studied about this nephrocheck, serum NGAL, urine NGAL. All the important part you write, whichever you can remember. I have discussed this in detail in the other part. Then what are the management strategies? So first, for the general management of CRS, there is use of diuretics. Loop diuretics are used to relieve the fluid overload, monitor for worsening kidney function and electrolyte disbalance. Ultrafiltration or dialysis may be needed in diuretic resistant cases. Then there should be hemodynamic optimization, use of inotropes, dobutamine, milrinone if the cardiac output is low. Use of vasodilators, example is nitrates to reduce the preload and afterload. Blood pressure control to avoid hypotension. But you have to manage the hypertension to reduce the strain on both the organs, because hypertension accelerates the development of it damages the heart muscles and the kidney also. Then there is neurohumoral modulation using of ACE inhibitors, ARBs and ARNIs, which are important. Improve the survival in heart failure, but you should be used in caution with advanced kidney disease. Use of beta blocker, use of carbidopa and bisoprolol, especially in chronic heart failure patient. Mineralocorticoid receptor antagonist. This is useful. Spironolactone is useful in heart failure with reduced ejection fraction, but we have to watch for hyperkalemia and worsening of kidney function. Now, the newest in the block is the SGLT2 inhibitor, dapagliflozin. All the studies have shown they are emerging. They are emerging as a cornerstone therapy for both heart failure with CKD. We have to correct the metabolic abnormalities. We have to treat hyperkalemia, acidosis as anemia. You have to use sodium bicarbonate cautiously in metabolic acidosis. Can consider erythropoiesis stimulating agents for anemia and CKD, but not in active infection stage or sepsis stage. Use of last retort is the use of renal replacement therapy for patient with worsening kidney failure unresponsive to medical management. So this is basically a flow chart where you consider for the decongestive therapy in heart failure patient, in acute heart failure, HRS1. There is a occurrence of worsening renal function during treatment. If the answer is yes, check for the diuretic response. If it is good, then it is a pseudo worsening renal failure. If it is poor, check for congestion. You have to assess for the CVP, consider for TT, all the volume assessment you have to do. If it is absent, then it was a pseudo. And if it is present, check for hypoperfusion and hypotension. If it is absent, then increase diuretic intensity and consider IV vasodilator. Improvement, worsening of the renal function due to factor congestion, and no improvement, therapy resistant worsening renal function. If the hypoperfusion, hypotension is present, then you have to discontinue the BP lowering drugs and consider for inotropes and the vasopressor if there is decrease in cardiac output. So it was a worsening renal function due to hypoperfusion. Then this is the type 3 management, this AKI. This can be also made in a chart. If the oliguria is present, yes, then measure the urinary and serum sodium, serum urea, and serum creatinine. If the urinary sodium is less than 30 milliequivalent per liter, or serum urea by serum creatinine ratio is more than 20:1, it is pre-renal AKI. Then there is volume depletion. And if the oliguria is not present, then you have to go for renal ultrasound to rule out whether it is hydronephrosis. Then it shows post-renal AKI, normal size, or bilateral small kidneys. If it is normal size, then it might be a parenchymal disease. You have to do urine analysis and renal biopsy. For chronic kidney disease, you have to manage by avoid nephrotoxic drugs, aminoglycosides. You have to manage albuminuria by RAS blockers, hypertension by RAS blockers, beta blockers, and mineralocorticoid receptor antagonists. You have to manage the electrolyte imbalances. You have to manage dyslipidemia, anemia, fluid overload, acidosis, and lastly, treat any reversible causes. And the last resort remains RRT. For management of cardiorenal type 5, it is actually the systemic disease which is causing the cardiorenal disease type 5. You have to treat that. So you have to go for a multimodal management that can be pharmacological. Early and definitive diagnosis is needed for non-pharmacological management and treatment of the underlying causes. And lastly, if does not resolve, then go for palliation. So these are the different evidence-based RCTs comparing pharmacological therapies for fluid overload and ultrafiltration in patient with acute decompensated heart failure. This was the rapid trial, unload trial, CARES heart failure trial, avoid heart failure trial. If it might not be possible to remember everything, but important thing you have to know that initial state the outcome may be similar. Use of diuretics or RRT. First, you have to always try with the for treating of CRS. You have to always use diuretics. If it is unresponding, then you have to go for RRT initiation. So I was told to make a few notes about which review articles to study for the upcoming exam. So this is one of the nicest review article published in Annals of Intensive Care, given by Marlies Osterman. This is the biomarkers in acute kidney injury. My whole talk on biomarkers was partly taken from this. So it is one of the most, so I'm not discussing this in detail. So the biomarker part you can refer to. This is one of the, before going to exam, you should read this article. And another article, which is an important topic also, and one long question also, sepsis associated acute kidney injury. You have to study the recent advances in enrichment strategies and the subphenotyping. Phenotyping in sepsis induced AKI is very important question nowadays. It might come in your paper 3 of recent advances. So this paper you should read. So basically they have started this paper with definition of phenotyping. What is phenotyping? What is endotype? What is subphenotype? What is prognostication? What is predictive? This drug response, heterogeneity of treatment effects, treatable trait, enrichment. They have divided into subphenotype 1, 2, 3, and then they have made this endotype and then treatable traits. And ultimately, they have divided this these are the recent advances you should follow for kidney recovery, functional outcome, and for preventing any remote organ injury. You have to make the electronic alerts and order sets, follow up of the patient. Then you have to give the hemodynamic support, organ support. Now there is a massive role of machine learning in AKI, AI in used for prediction of AKI also. There are some papers you should read for the recent advances. And biomarkers, all the latest biomarkers have been discussed, and subphenotyping is also very important topic, phenotyping in sepsis and drug development and kidney protection. Thank you.
Thank you, Dr. Trishita. It was an extensive presentation, but I think it was very useful. She has touched upon a lot of important topics. So initially, I think the timing of RRT will be asked to you in your Viva also and theory also. So early initiation only when these 4 urgent indications are coming up, that is severe metabolic acidosis refractory to bicarb, severe fluid overload refractory to diuretics, refractory hyperkalemia, and fluid and uremic complications. So Apart from that, always answer in a way that delayed strategy will allow for some spontaneous renal recovery, which has been shown in a lot of trials, and none of these trials have any survival benefit for early RRT. After that, I think a lot of other important questions like Vexus has also been covered, how it has been used as the new ultrasound tool also for combining IVC with hepatic, portal, and renal venous Doppler patterns. And you should prepare for that as a short answer question. Contrast induced AKI is another short answer question which they ask. Try to define it as she did. So, definition, risk factors, pathophysiology, and how do you prevent it and how do you manage it. So, these 5 important bullet points should be covered in your answer. And these key points should be definitely there in your answer. Of course, mechanism also. So, definition, risk factors, mechanism, how do you prevent it and how do you treat it. And after that, cardiorenal syndrome is also a very important topic. So, again, definition of cardiorenal syndrome, 5 types of cardiorenal syndrome, what is the pathophysiology, and what is the management principle. She has nicely covered in her slides. And all these questions are very, very important for exam. I would ask you guys to ask any doubts. So both Debotam is there, Trishita is there, Dr. Arindam is there, I'm there. So any doubts in nephrology section, we can try to clear it up now itself, or you can also email us or message us if you need any help.
You can also put your queries and doubts in the
Chat box.
WhatsApp group. Yes, WhatsApp
Yeah.
group.
And
Even
also
later, while going through the presentation, I'll add Dr. Monalisa to the group so that you can get the answers from.
Great. So I don't see any doubts in the chat section. So should we end this session, Sudeshna?
Yes, ma'am. I think
Okay.
we can end the session here, and tomorrow we again meet at 6 o'clock. I will send the topics by tonight so that we can again meet up again.